All right, we are going to get started with our second round of resident presentations. It sounds like there's a lot of good discussion, probably some of it about ADHD, but I'm going to have us all focus now on our next section. All right, thank you. So it is my privilege to continue with our next set. So we have three wonderful presentations. They came as a group from Spokane. So our next three physicians are all coming to us from the other side of the state. So I'd like to first start off by introducing Dr. Iman, who's going to be talking to us about an interesting case in the rheumatology spectrum.
Perfect. Hi, everybody. My name is Taylor Iman. I'm a resident from IMRS, and I'm going to be talking to you all about a toxic twist. So we had a 22-year-old female patient, and she came in with kind of nonspecific symptoms: abdominal pain, diarrhea for 1 week, fever of 104 at home. She has a past medical history of lupus nephritis, and she had a kidney transplant a couple years back. And so in the ED, they got some history for her. And these were her intake vitals. She's tachycardic, she was tachypnic, she was febrile. But what really drew everybody's attention is that she had AST and ALT at elevations of 90 and 96 respectively. Imaging was normal. But this prompted them to get further history, and what they ultimately found is that the woman's mom, who's a registered nurse, had given her 6 incremental doses of Tylenol over the last 24 hours to treat that 104-degree fever. She also maybe had some heavy drinking in the week leading up to her symptoms beforehand, but that was a week prior. And so when you're worried about, toxic ingestions, who do you call? There's only one person for me, and that's poison control. And so they called poison control, and they asked, is this enough to see the level of drug-induced liver injury that we're seeing? And the answer was maybe. We don't know. So the recommendation is to start N-acetylcysteine, at least for the treatment. Unfortunately, she developed an anaphylactic reaction to the N-acetylcysteine, and so called poison control again, and they said, well, if she has an elevated Tylenol level, then we probably should continue treating her, but maybe at a higher level facility for closer monitoring. But that came back at less than 1. But in the meantime, she was still in the process of being kind of transferred to this higher level facility, and ultimately she transferred to another facility with a diagnosis of accidental Tylenol overdose. I included a nomogram in this slide because it can be helpful for deciding whether or not you initiate N-acetylcysteine, but it was not helpful in this case because this is 4 to 24 hours after a single ingestion, so this was not reliable for her. So on that first day, she was feeling better. She was hemodynamically stable, so they withheld the NAC. But on day 2, her LFT started uptrending. She started having significant abdominal pain. Imaging was negative. By day 3, she had 103-degree fever. She had lingering cough and sore throat, and so that people started expanding the workup, thinking, maybe we did miss an infection. Started empiric antibiotics. And on day 4, the patient was febrile, she had tonsillar exudates, she had abdominal pain, she had elevated AST and ALT, and she also noted significant distress from day 1 through day 4 related to that initial diagnosis of accidental Tylenol overdose and perceived biases she felt like she was experiencing from the medical system because of it. Acyclovir was ultimately initiated because there was concern that maybe we missed a viral illness, especially in the setting of her being immunocompromised. And on day 5, the patient developed vesicular lesions on her tongue base, and so a monospot and an HSV was sent. And the culprit was HSV2. At this point, infectious disease was on board, and because she had a negative IgG, this was thought to be a new infection rather than reactivation. That exquisite abdominal pain that she had been complaining about the whole time was that maybe this is actually HSV hepatitis and a disseminated infection. At this point, Tylenol was excluded as a red herring, and this was probably not likely to have contributed to her diagnosis at all. So some HSV hepatitis pearls. This is a very rare but very deadly manifestation of HSV, less than 2% of viral causes. It is particularly dangerous for our immunosuppressed patients and patients in their 3rd trimester of pregnancy. However, in the research that I found, even up to 25% of immunocompetent patients also are impacted by this disease. Presenting symptoms are nonspecific. We're really lucky that this patient had those mucocutaneous lesions because that's ultimately prompted the HSV to be sent, but 20 to 50% of cases do not present with that. There's no reliable form of imaging for HSV hepatitis. And actually, this was a relatively benign case. Most of the studies that I found reported 100 to 1,000-fold increase in those liver enzymes. However, I did find case reports, particularly in immunocompromised patients and one pregnant patient that also had a relatively benign course, as she did. The gold standard for diagnosis is liver biopsy, but I want to caution you all not to wait for that liver biopsy to start initiation of acyclovir treatment. And in fact, one study that I found, a retrospective study, said that 31% of cases were diagnosed with biopsy at time of autopsy, and only 8% of those cases were thought to have had HSV beforehand. So the recommendation treatment is high-dose IV acyclovir, but even without treatment with acyclovir, this is a very deadly, high morbidity and mortality disease of 51 to 55% even with the correct treatment. So on day 5, that acyclovir that was already started was increased to the higher dose, and she had a rapid turnaround. She had near total resolution of that abdominal pain that she was experiencing. The mucocutaneous lesions had improved. She was afebrile, and she was feeling a lot better. But because of that initial diagnosis of a Tylenol overdose, she expressed a significant desire to leave. It took too long to reach that diagnosis. And on day 7, she self-directed discharge on only a day and a half of IV acyclovir with the plan to continue it orally outpatient. I want to give this caveat that without that biopsy, I cannot definitively tell you that this was a case of HSV hepatitis. I don't have that information, but in my multiple conversations with infectious disease doctors thereafter regarding her case, in the absence of all other workup coming back negative, this is the most likely conclusion. There's really no other reasonable explanation for her rapid turnaround. This is also an important case for recognizing biases. After admission, it's really easy in transfer situations to rely on our colleagues and to kind of go based on the workup that they had at outside facilities. But we always, especially in immunocompromised patients who have transplants, we need to be having broad differentials for fever. And then prior to admission, there was kind of a confirmation bias, probably an over-reliance on that initial history of the Tylenol, even though that APAP came back less than 1, that kind of challenged that initial diagnosis. So my ultimate pearls, HSV hepatitis is a rapidly fatal manifestation, and we should be recognizing it early, and if you do have any suspicions, do not hesitate to start acyclovir. The gold standard for diagnosis is liver biopsy for HSV hepatitis, but do not wait, once again. Broad workup of fever is essential in patients with kidney transplants and immunosuppressed patients, and we should always be having a broad differential when they're coming into our hospitals. And lastly, check and recheck your biases. It was really unfortunate that this patient's experience with the medical system led to suboptimal care in her case. I do feel somewhat have a lot of gratitude that I have the opportunity to share her case with you all so that we can better recognize it in the future. That's my case. Thank you.
We have time for a few questions.
In retrospect, do you think she really had anaphylaxis or oral symptoms and rosacea from the HSV?
The question was, in retrospect, do we actually think she had anaphylaxis? That was conducted at an outside facility, and so reviewing their notes, it really did seem like an anaphylactic reaction. She did have throat swelling, she did have angioedema, and so I do think that was more consistent with a anaphylactic reaction, but I don't know, I wasn't there. Any other questions?
I'm curious why there was not a thought of somebody who's immunocompromised in fever that a possible infectious etiology was not arrived at sooner, thought of sooner.
Absolutely. Yeah, the question was, why didn't we think of an infectious etiology sooner? That first day when she arrived, in talking with the admissions team, she was at that time hemodynamically stable. Her fever had completely resolved and her abdominal pain had completely resolved. And so at that time, there was thought maybe there was an infection. As soon as she did have more symptoms in the days leading up to that, or in the days following, that's when workup was initiated. Thank you.
All right, we are just switching slides and Connor, right? Okay. All right, we are going to continue with our Spokane theme, and I will turn it over to Dr. O'Neill, who will take us into neurology.
All right, yeah, my name's Connor O'Neill. I'm a second-year resident at the Spokane Internal Medicine Residency, and my title is Stumbling Towards Clarity. So we'll start with the case. We have a 72-year-old female with past medical history of anxiety on escitalopram, no other past medical history, who presented to her primary care doctor in 2021 to establish care. She came in with really a bunch of multiple kind of non-specific complaints, including some episodic dizziness upon standing, some short-term memory loss over the last couple of months, and then she was describing these episodes of insomnia that she was having and some bizarre dreams over the last month or so. On chart review, differential diagnoses at that time were medication-induced sleep disorder, electrolyte disturbances, Lewy body dementia, and Parkinsonism. Further workup was warranted. Labs included a B12 that was normal, a TSH within normal limits. Chemistry panel also was mostly normal other than a sodium of 132, which I know some of you would be dying to get those urine studies. A normal CBC, and of course negative syphilis. Plan was to stop escitalopram and return in about 2 to 3 weeks for more of a formal cognitive evaluation. However, our patient, in fact, did not return 2 weeks later and was not seen in clinic for about 2.5 years. She, at that time, came back to clinic and was describing more frequent symptoms, and most concerning to her was, again, these acute episodes of dizziness upon standing. And so her exam at that time was really normal. She had no nystagmus, she had no neurologic deficits, her gait was totally normal, but because of that dizziness, we thought maybe BPPV was on the differential, so sent her to vestibular therapy. About 2 to 4 weeks later, she sends a MyChart message that was kind of concerning. She described these episodes where she'd be walking at a completely normal pace and then would kind of start to slow down, almost coming to a complete stop. So brought her back into clinic, and this time she started to have, she was having a staggering gait, profound bradykinesia in all of her extremities, but of note, she had no resting tremor or rigidity on her exam. So next thing we did, we got a brain MRI, which was negative, and now at this time at the top of our differential was Parkinson's disease. So we sent her referral to neurology. She was actually able to get seen about 3 weeks later, and they started her on some Sinemet and started to notice some improvements relatively quick and was able to start doing some of the things she wasn't, or she was able to do prior to her symptoms starting. So the official diagnosis she was given was postural instability and gait disturbances, PIGD motor subtype of Parkinson's disease. And so Parkinson's disease, as you know, it is a clinical diagnosis, and there's quite a bit of diagnostic criteria that goes into that, which I won't get into all of the weeds there, but Parkinsonism is described as the presence of bradykinesia and then either rigidity or tremor. And then there's some exclusion criteria and supportive criteria, like I said, I won't really get into. But you'll remember our patient didn't have rigidity or tremor on exam yet, was diagnosed with Parkinson's disease, and had improvements with Sinemet. And so really what that's telling us is there's a lot more varying clinical presentations of Parkinson's disease, and it doesn't really fit necessarily into this neat and tidy box like maybe we hoped Parkinson's disease would. So just a reminder of the pathophysiology here. So patients who are diagnosed with Parkinson's disease, they getting a depletion of their dopaminergic neurons. And so dopamine is that neurotransmitter that sends signals kind of responsible for things like movement and sleep and mood disorders. And so as these patients develop in their disease, they get a disruption in the connection from their thalamus to the motor cortex, and they start to experience symptoms very similar to how our patient presented. And so I threw this graphic on here just kind of as a reminder, or just to demonstrate how dopamine is used in the body and why the treatment for Parkinson's disease makes sense. So levodopa is converted into dopamine and then is used as a neurotransmitter throughout the body. And so we give levodopa to really compensate for that loss of endogenous dopamine in these patients. And then additionally, carbidopa is used to block that conversion of levodopa peripherally to dopamine, so more levodopa gets into the blood-brain barrier and can be used to transmit signals throughout the body. So Parkinson's disease, there's 3 main motor subtypes that we see. Tremor dominant is the most common, postural instability and gait disturbances like we're talking about today, and then there's an akinetic or rigid subtype as well. But more and more subtypes are being found to kind of using genetic testing to further characterize Parkinson's disease. So really PIGD mainly characterized by this decrease in ability to prevent falling. There's an impairment in their centrally mediated postural reflexes, and so a lot of time these patients' initial presentation will be that they've had a fall at home, or just walking they're feeling a little bit more unstable than usual. They'll have profound bradykinesia, but of note, there is no resting tremor on exam in these patients. There's less responsive to dopaminergic therapies, and there's more of a rapid progression and a greater psychologic impairments compared to our other subtypes, or tremor dominant mostly. This is a pretty busy slide here, but just asks you to kind of focus on those ones that are boxed there, but kind of goes into detail explaining the difference between PIGD and our tremor dominant subtype. As I said, tremor dominant accounts for about 75 to 80% of the diagnoses of Parkinson's disease, and it's typically diagnosed earlier in the disease course as well, probably because if we see that tremor on exam, Parkinson's disease goes kind of high on our differential, so it's diagnosed sooner. I also mentioned akinetic subtype, and it's less common as well, but it's similar to PIGD in the fact that it has a rapid progression and a poor prognosis, really. But they present with basically they're unable to move their muscles voluntarily. It's quite devastating. So just wrap up here, take home points. REM disturbances, I encourage you to put Parkinson's disease on your differential when you have a patient who's middle-aged or elderly who comes in and starts to describe sleep changes. Just think of Parkinson's disease and see if that fits the rest of their symptoms. And then, of course, bradykinesia and gait instability as well. PIGD Parkinson's disease does not have that classic tremor that we think of with Parkinson's disease. And then PIGD is rapidly progressive compared to our tremor dominant subtype. And so, you may think, why do we in primary care about these different subtypes of Parkinson's disease? We're going to send them to neurology, they're going to get started on Cinemet, and it's their thing. Whereas, I would say that the earlier we can see these different presentations in our clinic, we can recognize these things, the earlier we can get them diagnosed and get them into neurology and get them started on treatment. And then this one really goes without saying, but our patient had Parkinsonism on her differential diagnosis 2.5 years prior to her official diagnosis, and had we been able to see her in clinic sooner and earlier, it's possible she would have been diagnosed earlier and gotten the treatment she needed. Thank you. Yeah, the question was initially when she came in, what would you look for on physical exam that would clue you into this initially? And for her, there really wasn't a lot. There was nothing on physical exam that we saw when she initially came in. There was no gait changes. It was all kind of just subjective complaints that she had. There was nothing really that we could find. But having, looking back, seeing that she had these REM disturbances, having her maybe walk for us more in clinic, and I don't think that happened necessarily that first time, but watching her gait would probably be, I'd say, the thing to look out for.
You said she described it like a lightheadedness. Do you think she was just kind of misdescribing the ataxia and imbalance? Because people say dizzy, they think all kinds of things. Or is there something common among the cases?
Yeah, the question was, she described these episodes of dizziness initially. Is it possible that she was experiencing ataxia and just did not, was unable to describe those symptoms appropriately or properly? And I would say, yeah, probably. There's not a lot of data that, these patients they get impaired, like their postural reflexes, like I said, so it's possible she had some orthostasis, but it probably is a combination of that sense of ataxia with gait changes that she was experiencing, and probably a combination of both. Yeah.
Thank you.
Yeah.
I am looking for the mouse. There it is. On the right. We have our final resident speaker of the afternoon, and we actually have a returning speaker. So Dr. DeWald is joining us again this year with another case. Thank you.
Can't keep me away. Just came back for more. So my name is Laura. I'm a third-year internal medicine resident with the Spokane Internal Medicine Residency Program. And my presentation I have called Metformin Mishap, a case of near-fatal toxicity. So the patient was a 75-year-old male, who presented with information you can see here on the slide. He was in profound shock, presented to the ICU in profound shock of unknown etiology. He was so obtunded that we couldn't get any past medical history from him. He had acute renal failure with a potassium of 7.8, a metabolic acidosis with a pH of 6.8 and a lactate of 18, and a leukocytosis with a white count of 80, a thrombocytosis with platelets of 842. These are just some of the data that I found interesting. There was a lot more that was wrong with his labs. And because he was obtunded, he wound up intubated. We got plenty of imaging, as we do in the ICU, and really all of it was very unremarkable. The only thing that we found was very small bilateral pleural effusions. So from there, our working diagnosis was sepsis because we weren't really sure what was going on with this gentleman. We did start him on empiric antibiotics, stress dose steroids, an insulin drip, and a bicarb drip. We had planned to start him on CRRT, but he was so profoundly hypotensive that it was thought that he wasn't going to tolerate it. So the CRRT was delayed for a while. And because he was doing so poorly, we actually started having conversations with the family about transitioning to comfort care. So the family decided to take the night to think about comfort care and left. So later on, the evening intensivist came in and started doing a deep dive into the chart and noticed that metformin was on the patient's MAR, outpatient, and then actually started to suspect metformin toxicity. And so the need for CRRT became more and more imperative. So we started him on the pressors that you can see on the slide here. And just to put a little bit of context to this, I'm sure a lot of you already know, but these are much higher doses than a patient would normally be put on. The usual maximum dose for norepinephrine is 80 micrograms per minute, and he was on 100. For vaso, usually you max out at 0.04 units per minute, and he was on 0.09. And then for epinephrine, he was on 50, and the usual max dose is 40 micrograms per minute. But it worked. He was able to tolerate the CRRT, and he didn't have any significant vasoplegia on these doses. And he was actually weaned off the pressors in about 12 hours and extubated very shortly thereafter. He was transitioned to the floor, and he was discharged a few days later. Yeah, it was wild, which is why I'm presenting it. So I'm going to quote the consulting nephrologist because I think he summed it up really well. He said, quote, "Progress in the last 10 hours can be stated as nothing shy of miraculous. The patient required astronomical doses of pressors, and despite this, had no evidence of shock liver remodeling. He most likely was vasoplegic. The etiology here is increasingly more likely metformin toxicity in the setting of AKI." And he was correct. We sent out a metformin level, and it came back at 31 micrograms per milliliter. A usual a level that's been associated with metformin toxicity is greater than 5 micrograms per milliliter. And when the patient woke up and he was able to talk to us, it turned out he'd had a GI illness in the few days preceding his ICU admission. And so we suspect he just developed a profound AKI that then put him in a situation where he could develop metformin toxicity. So just a little bit about metformin toxicity, and I'm sorry to bring you back to the Krebs cycle, but this will be brief. Metformin, as you can see here on the slide, blocks a step in the mitochondrial transport chain, which is where NADH is converted into NAD, and that is then converted into ATP. So when metformin blocks that step, it then backs up the Krebs cycle, which then causes pyruvate to be shunted into lactate, which is why these patients wind up with such severe lactic acidosis. There's two different subtypes. The first type is called metformin-induced, and that's usually related to either an acute overdose of metformin, so patients generally have to take up to 20 grams of metformin in order for this to happen, versus a subacute accumulation in the setting of an AKI, such as what happened with our patient. There's also the subtype called metformin-associated lactic acidosis, which is when a patient already has shock of some sort and the metformin just amplifies the degree of the acidosis. The presenting symptoms are fairly vague. You can see them up here and read them for yourself. But just like all of the cases that we've had, they're fairly vague symptoms. The mainstay of treatment is dialysis, and specifically you can use something called the XTRIP guidelines to help you decide if a patient would benefit from dialysis. Those state that for a patient with a pH of less than 7, a lactate of greater than 20, and in patients who don't respond to more conservative measures, they may benefit from dialysis. And some of those are listed here. Insulin, it's been theorized, can help restore the Krebs cycle by reducing the conversion of protein into pyruvate. Methylene blue can, in theory, bypass that cytochrome that metformin goes after and restart the Krebs cycle. And then, of course, you can always start someone who has a pH of less than 7.2 on a bicarb drip. These are a few studies that I came across when I was doing my research for this talk. The first one is an observational study from 2017 that took 105 patients with metformin-associated lactic acidosis and found that for those who had a time to dialysis of less than 6 hours, had a lower 30-day mortality. And then the second is a systemic review from 2009 that took 22 cases of metformin overdose in which 5 patients died, and found that for all of those patients, their pH nadir was less than 6.9, their lactate was greater than 25, and their metformin concentration was greater than 50. So in truth, I couldn't find very many strict guidelines to help us prevent metformin toxicity, but I'll just leave you with a few pearls that may be helpful. And those are to prescribe metformin and caution to patients with a GFR of less than 30, avoid concomitant alcohol consumption, or advise your patients to avoid that. To stop metformin, or at least to consider stopping metformin for 3 days prior to IV contrast, and then consider stopping metformin for 2 days prior to general anesthesia. So in summary, if you have a patient who presents in very profound shock and with a severe lactic acidosis, you may want to consider metformin toxicity. There are the two different types that you may want to consider, the metformin-induced and the metformin-associated. And dialysis, usually CRRT, is the mainstay of treatment. And that is all I have. What questions can I answer?
Curious in your reading if you came across anything about stopping metformin in anyone who's had gastroenteritis or might be dehydrated, since that's your suspicion of this patient.
Yeah, so the question was, had I read anything about stopping metformin in patients who've had gastroenteritis or have other reasons to be dehydrated? And honestly, I thought about that question in preparation of this. I didn't come across anything in particular when I was reading, but I was just thinking about anecdotally, is that something that I would consider cautioning patients, especially patients who that we know have lower kidney function or haven't had their kidney function checked in a while? Would I, advise my outpatient patients to perhaps hold their metformin if they developed a GI illness? Probably. Now, after seeing this, I've actually seen it twice in our ICU, so yeah.
What is it that led that intensivist at night to identify the cause?
Yeah, good question. So the question was, what led the intensivist to start thinking about metformin toxicity? And it's because he'd seen it before. And so maybe recency bias, I don't know. But yeah, it was because he was familiar with it. And I think, really the key here is that the lactic acidosis seemed, and the pressor needs seemed so out of proportion to, a sepsis reaction. So.
Thank you very much.
Yep.